clinical presentation of neurotrophic keratopathy. So it's usually in the, almost always, in fact, I wouldn't say usually, almost always in the inferior part of the cornea, because the superior part is protected by Bill's phenomenon. And it's usually horizontal, and the edges are rolled in or heaped edges. They are usually clean, no stromal infiltration, no signs of infection, unless secondarily infected. There might be signs of melting of the cornea. And it's really indolent, so the patient might not feel the actual, or might not report the actual symptoms of corneal ulcer or corneal epithelial defect. It's resistant to reepithelialization, resistant to treatment, so it remains the same for a very long time. Afterwards, it might show thinning, melting, dysmetocele, and eventually perforation. If it's perforated, it would need cyanoacrylate glue or something to treat this perforation, but this is not the scope at the moment. So, rule of confocal microscopy. In the ophthalmology investigation, we'll come back to the confocal microscopy, but I would let you know for your exam that this can be mentioned as a high-yield topic in examining a patient with neurotrophic keratopathy. So confocal microscopy can take photos of every single layer of the cornea and can show the arborization of the corneal nerves. It can differentiate even between cases of diabetic neuropathic keratitis, and it can evaluate the cases with neuropathic pain and neurotrophic keratitis. It's mainly used, and the familiar indications are infectious keratitis, acanthamoeba, and blah blah blah. But it's really essential, not essential. It's really useful in evaluating patients with neuropathic pain, neurotrophic keratopathy, and diabetic neurotrophic keratitis. So we have here two photos. The one to the left is of normal corneal blood vessels, and the one on the right shows a cornea with neurotrophic keratitis. You can see how densely packed and arborized corneal nerves here, but this doesn't mean that they are working properly. This doesn't mean that they are conveying any sensation. On the contrary, it's a neuropathic cornea. Management of these cases involves aggressive preservative-free lubricants in the form of drops, gel, during night, during daytime, every time. Autologous serum drops. Few hospitals provide this. So extracting the serum without any cellular component, without plasma cells, without anything, is essential for the trophic environment of the cornea. It contains growth factors naturally found in the human serum for the cornea to regenerate. Afterwards is bandage contact lenses. So this is something that's available everywhere and handy. Bandage contact lenses, as per their water content, can be classified into low water content, medium, and high. So, in contrast to what the name means, low water content bandage contact lenses provide more moisture. It's more lubricating. It resists dryness. while medium and high are more for mechanical protection. Hence they are preferred in cases after corneal transplantation or corneal surgery, for example. These are the first three simple steps. But if the cornea starts to melt, there is tissue loss. So you start to think about providing oral agent like tetracycline or doxycycline, which has antimetalloproteinase effect and resists further melting. It works, in fact. It doesn't help to regenerate, but it works to delay perforation in this mesothelin. Other innovative medications like topical recombinant human nerve growth factor, these eye drops are used and they have very promising results. The only drawback is they cause pain as adverse reaction during the course of treatment. Surgical treatment might involve amniotic membrane graft, Gunderson flap, or tarsorrhaphy. Amniotic membrane graft is very useful. You just suture the amniotic membrane on top of the cornea. Gunderson flap, you can use it to do either a full perotomy or modified Gunderson flap, which is partial perotomy, and then dissect the conjunctiva down and take it up to suture it and cover the cornea completely. Tarsorrhaphy is the easiest way of managing these cases, and consider this on case basis. So either paramedian, median tarsorrhaphy, and permanent or temporary.